All right. Well, while Dr. Flink goes ahead and gets her slide set up, I just want to take a moment to welcome you all to today's Doctor is In program to talk about monkeypox. So for any of you who are new to Doctor is In, and maybe are just tuning in because of this very present current topic, Doctor is In is a partnership between the Elder Initiative at the William Wade Community Center and the Jefferson Department of Family and Community Medicine, which includes their division of geriatrics. And we've done this program series for a couple of years now, hybrid, or all virtual for the last 2 years, to have doctors come in and present on different relevant health topics for the community, all unpaid, doing this on their outside of their many responsibilities as doctors, even throughout the pandemic. And so today we are happy to be joined by Dr. Lily Flink, who is a geriatric fellow at Jefferson. We have a new class of fellows at Jefferson that has just started. So this is Lily's first Doctors In program with us, but very happy to have her. Just a couple of housekeeping things. You are free to add any questions throughout the program. There are 2 ways to do that. You can use the chat feature, which you can access in the bottom of your Zoom toolbar. You can also use the Q&A feature. Do know that when you're putting things in the chat, your name is attached to it. If there's anything that you would rather ask anonymously, you can do that using the Q&A. And there is an option to keep your name off of your question. I will be relaying all the questions to Dr. Flink, either as they come in, or Lily, I will ask you sort of, if there are good points to pause in the presentation, but I'll keep an eye on the chat so you don't have to. And with that, would like to turn it over to Dr. Lily Flink to lead us through today's presentation.
Sounds good. Thank you so much. And I'm sorry, I'm having some difficulties, and I'm usually pretty tech savvy, but I'm struggling to get my slides to share with my notes. So I'll just go notes list. And if there's anything I want to add at the end, I will add that in. But let me make sure you can see my slides. So let's see. This is what I want to be sharing. And are you seeing it in a presenter?
That looks perfect. Yep, we're just
Okay.
seeing the slides.
Great. So I am really happy to be here talking with you all about monkeypox today. Thanks for coming. And again, thank you for your patience. This can be really informal. And like David said, I'm happy to take questions at any point. And that kind of takes me into the next slide. So I have no conflicts of interest with this topic. And just for full disclosure, I'm not an infectious disease doctor. I'm not an expert in monkeypox by any means. I am trained in family medicine. I just finished up my residency and, like he said, started my geriatrics fellowship. And also just, as a caveat to this talk, the information we have on monkeypox is constantly evolving. I've been trying to stay up on the numbers and the news and the updates over the past couple of weeks since I learned about giving this talk, and things are really in flux. I am trying to base everything that I will share with you in data and in scientific evidence. I am sure there are a lot of anecdotal stories that people have, and I am really happy to hear those too. But it's harder to speak on those things from the perspective of a physician. I think it's helpful to go over a bit of the history of monkeypox, just to understand the context of where we are. So monkeypox is a virus. It was first discovered in 1958, initially in monkeys during a study. And the first human case was documented in 1970. And at that time, it was spread from animal contact exclusively. And up until recently, any cases of monkeypox that we had were linked to travel in Central and West Africa, that the virus is endemic to that area. We were vaccinating folks for smallpox like through the 70s, which is the same family that monkeypox is from. And interestingly, officially stopped vaccinating anyone for smallpox in 1980. So anybody who grew up after that time would not have any immunity to monkeypox or smallpox currently. And actually, in preparing for this talk, I also learned that even those who were vaccinated for smallpox probably don't have immunity to monkeypox at this point. So like I said, this is a virus. It's part of the pox virus family. What we know about monkeypox in general is that there are two strains, the West African strain and the Congo Basin strain. The West African strain is what we've been seeing in the US and in this outbreak around the world. And that tends to present with milder symptoms and is rarely fatal. This all started in May of this year, and these numbers are accurate as of the past few days. So the most accurate one is the Philadelphia official case number. We're at 128 cases in Philadelphia, 8,933 in the US, and over 30,000 globally. This is certainly an underestimate. I think as education and awareness builds around monkeypox and its really varied presentation, we will start to catch up with numbers. But like we've seen with COVID, not that these are the same, but there's a lot of similarities in terms of how we're dealing with public health information in the US. And I think that, the numbers only tell us so much and really only represent people who are reporting those numbers and people who are presenting in healthcare settings. And there's obviously probably many more cases in the community. Importantly, most of the reported cases at this point are in the population of men who have sex with men or those with multiple or anonymous sex partners. And again, we will get into a little bit of that more. I see a Q&A popped up.
Yes, and so that was related to the vaccine, so it's okay to hold on this if you're going to get to it later. What was the question of does the smallpox vaccine protect against monkeypox?
Yeah, and
if someone was immunized as a child.
I mentioned that earlier, and I don't have full studies to go off of, but from the data that I've been seeing, folks who were vaccinated for smallpox likely do not have immunity from monkeypox. So that is important to know. So in terms of the symptoms for monkeypox, there's kind of 3 phases, and we'll get into that, but there's sort of 2 symptomatic categories that I want to talk about. One is what's sometimes referred to as the prodrome, and that can be before the onset of the rash, during, or after, or not present at all. So it's really not, the name is a misnomer. It doesn't necessarily happen before lesions appear. And that can be any combination of fevers, chills, headache, muscle and backache, swollen lymph nodes, sore throat, nasal congestion, or cough. And then with the rash, again, we're seeing really varied presentations. It can appear on the face, inside the mouth, on the hands and feet, including palms and soles, chest, genitals, and anus. And like I said, this really varies from person to person and case to case. This is the pattern that we're seeing, but it doesn't necessarily mean that someone will develop all of these symptoms, or really many of them even. And like I said, you can get just the rash without those other symptoms. And the rash evolves, and I'll go through that, but it can really look different at different phases and in different people. And both this prodrome and the rash can mimic other illnesses. So it's not always clear cut when somebody is presenting with monkeypox symptoms. I think especially with the prodrome, we know that has a lot of overlap with COVID symptoms. And with the rash, so many things can produce a rash, and even sexually transmitted infections can produce a rash like herpes and syphilis. So there is a good deal of like clinical diagnostics involved in these cases. And I do want to underscore that it is, even though this is something that can spread, it is really important to seek care from a healthcare provider if you think you might have this or you think you have any of these symptoms. One other word about the anal symptoms. From what I've gleaned, there are folks who are presenting with other anal symptoms if they have anal lesions, such as like bloody or mucousy bowel movements, or even like rectal bleeding. So that's also something that people should look out for. So these are some photos of rashes that folks have presented with. And like I said, this can be really varied. Oftentimes they're described as looking like pimples or blisters. And I think part of that is because there is a phase of the rash that comes with pus-filled lesions and when they evolve from blisters. So, but oftentimes they do evolve into a rash that is raised. They can be painful or itchy, but for most people, based on what we know, they're often painful until they start to crust, at which point they become itchy. So this is predominantly a painful rash. And I have read that people have had really varying numbers of lesions. So it could be just from 1 to thousands on a person. And it's hard to say exactly, who gets what. I see another question. Are there any significant features identifying those cases outside MSM transmission? The features are really similar, between individuals in that sense. Like there isn't, that we know of, differences in features and symptoms that are showing up in folks who do not have, or who are not men who have sex with men. So I think the answer to that would be no.
And how about with that for transmission? So transmission other than sexual contact.
I will go through
Awesome.
all the ways this can spread. Yep.
Awesome.
And I will make clear, but I am happy to repeat just to hammer it home. This is not only a disease that's affecting men who have sex with men, and it's not a disease that is that's not a sexually transmitted disease. It's not exclusively transmitted through sex or sexual acts. But those are great questions. Keep them coming to the screen. So this is more about the timing of the rash. Timing can really vary in terms of the illness course of the prodrome. But this is typically what we're seeing with the evolution of the rash. So I'll go through all these technical terms, but I think they're helpful so that we can understand how the rash evolves. So macules are usually how the rash presents first, and that's in the first 1 to 2 days. Macules are flat lesions, so the skin would not be raised, but you may have discoloration or redness on the skin. And then the macules evolve into papules, and papules are raised. And those are a lot of the photos that we are seeing circulate. And that happens over the next 1 to 2 days. Then the raised rash becomes fluid filled, and those are called vesicles. And that's like what blisters look like, what herpes can sometimes look like. And they're filled with clear fluid. And then pustules, like the name suggests, are filled with pus. And that's like an opaque, sometimes yellow, sometimes white fluid. And they become a little bit more tense at that point. Similar to another virus in the family of monkeypox, you can have umbilication in the middle of the lesion. So that means there's like a central dimple or a depression that can evolve in the middle of a lesion. And then those pustules will eventually crust over, and that can take up to a week. And then once they crust, scabs will form. Those will dry up and peel off, and new skin will replace it. And that can take about another week. The illness, all in all, can last anywhere from 2 to 4 weeks. And like I said, this whole rash itself lasts about 2 weeks for most people. And then give or take with the prodrome for people. And there's an asymptomatic period as well, in which folks are not contagious. That is a great question. So can getting monkeypox have any effect on your viral load if you are HIV positive and on antiretroviral therapy? I will speak about folks who have HIV a little bit later, and I can address this question at that time. That's a great question, and I will get to it.
And I just wanted to note too, to jump in, because I know someone is raising their hand. If we have time at the end, we can allow folks to unmute and ask your questions if you want to share something. Just in the sake of time, for now, let's keep the questions in the chat and in the Q&A. Just so we can keep things moving.
I'm also happy to provide my email at the end of this. And if people have questions, I can also look more into things. I will say time and again, like, we don't know everything about this. I certainly don't know everything about this, and I'm happy to look into things more for folks. Okay. So talking about spread, I think this is a concern for a lot of people, and something that we want to know about and ought to know about, so that we can protect ourselves and protect each other. This is spread from direct contact with the rash itself, or with scabs, or with bodily fluids. What I understand is that there has been virus seen in seminal and vaginal fluid, but it's not known whether that can transmit the virus itself. But my understanding is that, like saliva or respiratory secretions that you can come in contact with for a prolonged period with somebody who has lesions at that time, is how this can spread. So if you don't have a rash, it's very unlikely that you can spread monkeypox. Or if your partner doesn't have a rash, it's very unlikely you can get monkeypox from them. Like I said earlier, the rash is infectious and contagious until it crosses over, scabs fall off, and new skin forms. So there have to be no lesions left or visible before we can say you're officially not contagious. And then unfortunately, there's a long duration of illness in this disease, but there's also a variable incubation period. So symptoms can show up to 3 weeks after exposure. But for most people, they come up between 5 and 14 days after an exposure. I will talk about eczema and dermatitis too. That's a great question. And I don't have a slide on it, but we can get to it at the end. Actually, I do talk about those who are at higher risk, so we'll get to it. Okay. Sorry, this is a little bit blurry, but this is I'm a visual person, and I think charts help us understand things better. So just to review, we have that incubation period where the virus is developing. You are not contagious during that period, and that would be if you have a known exposure or unknown, but are monitoring for symptoms. And then this prodrome that may or may not be present, we're not certain whether you're contagious during that period or as contagious, but we know for certain once you have a rash, you are contagious, and isolation is recommended if you have prodromal symptoms or a rash. And we'll talk about specifically what that means in terms of isolation and what that looks like. Jimmy, to your question, are you infectious when initially asymptomatic? My understanding is if you are asymptomatic and don't have a lesion anywhere, it's very unlikely that you're contagious. If you have no symptoms at all, you are not contagious. If you have any of those prodrome symptoms like fever, swollen lymph nodes, body aches, cough, that is a time when you could potentially be contagious. But we know that once those lesions appear, you become much more contagious. So what does isolation look like? What we know is as soon as somebody thinks they may have monkeypox or has tested positive for monkeypox, they should isolate for the entirety of their illness, like I said, till they have no symptoms and no more lesions visible. And then in terms of precautions and isolation, there are some general things that people can do to try to limit their risk. most importantly, avoiding close physical contact with those who are positive or who may be positive. And I think, this varies from person to person, but I always think it's healthy and helpful to be open about exposures and infections and STIs and all those things with a sexual partner. And I encourage you to feel empowered to do that with sexual partners. But if you're not comfortable having those conversations, then the safest thing to do is to avoid, sexual contact with partners with an unknown status, and even close physical contact. And I've seen things from, avoiding crowded spaces with dancing, but I think that especially becomes risky when you have areas of exposed skin. And I know that's hard to say and hear in the summertime, but is definitely a way to keep yourself safe from spread. And then all the important, public health and infectious disease things we normally do to keep ourselves safe from other illness. So avoiding sharing cups, practicing good hand hygiene, washing hands frequently. For those who live with other individuals or who have roommates or family members who've tested positive, disinfecting items and surfaces is really important if they're using those, or if you're sharing items. There has been some mention of spread through like contaminated sheets and towels, but I would just say practicing, good hygiene with laundry and trying to not share towels or products like that with folks who have tested positive. And then if you are going to go out, like if we don't want people to stay home if they're sick without getting testing. We want you to go see your provider. And when you're going to do that, we do ask that folks cover lesions, wear a mask, and avoid public transportation. And it's interesting, the CDC is recommending wearing a mask whether you have respiratory symptoms or a rash if you're out in public, just because it's not fully understood the extent of respiratory transmission of monkeypox, I'm sorry. Since this virus is spread by prolonged skin-to-skin contact, shouldn't vaccines be available immediately to the homeless and vulnerable who may not be able to isolate at points of contact like shelters and relief centers, as well as community-based clinics? Yes, I mean, resounding yes, I agree. And I think, we're starting to see in the news, but this is often the case, that people who need healthcare and need vaccines and preventative medicines most often do not get them first, unfortunately, in our country and in our healthcare system. But yes, I really think that people who are, and we'll talk about this more, but immunocompromised, homeless, unable to isolate should be vaccinated. Right now, the tricky part with how this is all being rolled out is that all the vaccines are coming from the official national stockpile. And that people who are, and I'll talk through this more, but people are being prioritized if they've had an exposure. So even though homeless individuals or those who live in group settings are really vulnerable to this, we're trying to prevent illness. We're not in a preventive point. We're trying to prevent progression from exposure to illness. And hopefully when more vaccines get rolled out, we'll be able to prioritize folks who really also need this care. My understanding is that the way the vaccines have been assigned to different healthcare groups in Philadelphia, and I think nationally, it is based on like the communities that they're serving. And my understanding is that they are assessing the reach of different clinics and trying to prioritize those who can really reach at-risk populations. All right. I just want to make clear that monkeypox is not a sexually transmitted infection. I know there's been a lot of misinformation and stigmatization of this, especially in the LGBTQI community. And I want to be really clear about this, that sex is one of the ways monkeypox can spread because you have close skin-to-skin contact during sex, but it is not exclusively spread by sexual activity. It is a communicable disease, meaning it spreads through close contact, and is distinct from sexually transmitted infections in that way. I'll get to your question, Michael, about vaccines when symptomatic. And I just took this from the World Health Organization. I've been, I think progress can be slow, but I think it's been heartening to see the work that some of these larger organizations with a lot of power and presence in the health field are trying to reduce stigma. So the World Health Organization and CDC both said loud and clear, stigmatizing people because of a disease is never okay. Anyone can get or pass on monkeypox, regardless of their sexuality. Okay, so testing. Thankfully, unlike COVID, where testing was very slow to be rolled out for a prolonged period, we now have testing that is widely and commercially available. Any healthcare provider or clinic should be able to do testing for monkeypox. It is a simple swab. It's recommended to swab lesions twice, and those are sent out. And I believe like Quest and LabCorp and major labs are able to run these tests. Unfortunately, I don't know how much these tests cost or what the insurance reimbursements are like for those tests. But if you have symptoms, you should safely get yourself to a healthcare provider and ask for testing. And that's the best way we can keep track of things and protect ourselves and get treatment if you need. So some bit about vaccines. The vaccines that we have are from a vaccinia virus, which is another virus that's genetically similar to smallpox. And those were the vaccines that were initially used for smallpox. They are being used in monkeypox now. And the data that we have coming out of Africa so far shows that they are likely about 85% effective in preventing monkeypox. The expert opinion is that vaccination after exposure may prevent disease or lessen the severity of disease. Excuse me. And like I said, we are prioritizing folks who have been exposed to get vaccines. To the question that was asked most recently, Michael, once you are symptomatic, they are not recommending vaccination because it is not shown to alter the course of monkeypox once you start to show symptoms. It is ideal, and this is the CDC's current recommendation, to get vaccinated within 4 days of an exposure. Now, with the duration of the illness and the difficulty in getting vaccines, 4 days is a really difficult window. You can get the vaccine within 14 days of an exposure, as long as you still don't have symptoms at that point. There are a couple other vaccines that exist. I don't think they're being widely used, and I am not going to comment on those for the sake of time and everything I want to get through. So this is the current vaccine eligibility list, and it has to be both of the top two bullets, and the third one is a little bit tricky, so I'll go through this. These are folks who are eligible. Like I said, not all those who are eligible are getting vaccinated, and we're prioritizing people who are exposed. So eligibility includes those who are gay, bisexual, transgender, non-binary men who have sex with men, transgender, or non-binary individuals. You have to be 18 or over to get the vaccine. And then you have to have one of these criteria. So you have to also have multiple or anonymous sex partners in the past 14 days, and or been exposed to monkeypox or another STI in the past 14 days, or you have to have a new diagnosis of a sexually transmitted infection in the past 3 months. And I think that last section is really getting at risk, because we know that the incidence of monkeypox is high right now in communities of men who have sex with men or have people who have multiple sexual partners. So that just kind of assesses risk. Like I said, I think if you I haven't gone through the process or even been on the receiving end of it either, because I'm not in a regular clinic anymore in fellowship. But I think if you didn't have an exposure, I would imagine it's very challenging to get a vaccine in Philadelphia. And then again, just to be clear about what an exposure means, and this is another definition that has been put out. So an exposure technically is somebody who you've been sexual or in close contact with a partner within the past 14 days who's been diagnosed with monkeypox. They also include an exposure, and this is for the purpose of vaccination, as those who have had sexual partners in an area with known monkeypox cases. Now, I will say that doesn't mean if you have had multiple sexual partners in the past 2 weeks in an area with known monkeypox that you're certainly going to get monkeypox or develop symptoms. But again, they're stratifying risk and trying to vaccinate those who are at a higher risk of developing monkeypox. This is a new question. Yes, we'll get to HIV in a sec. So.
And I just wanted to clarify with what you're saying. So the vaccine guidelines, these are coming from the Philadelphia Department of Public Health. Is that right?
Yes. So the second one, or sorry, this first one is from the Philly Department of Public Health, I believe.
Great.
And then the CDC also defines exposure here.
Just want to make sure everyone was aware that Lily is not setting these criteria.
I'm not setting these criteria, and I think I don't share that to like incite fear. I think knowing what counts as like exposure or high risk can empower people to be able to advocate for getting vaccines for themselves. Because I think, unfortunately, while this should be rolled out for people who are at highest risk, we all know from the healthcare system that you often have to advocate for yourself and for family members to get the things that you need. So again, this data is evolving, but from what I've seen up until this point, we are not really seeing worse disease in folks who have HIV, who are undetectable and have strong immune function. For those who have advanced HIV or are not virally suppressed, you can be at an increased risk of severe disease, but it's also not guaranteed in those individuals. We know that vaccination with the main vaccine that we're offering is considered safe for people with HIV. And up until this point, it has been shown that antiviral treatments do not have many interactions with the antiretroviral meds that people are on for HIV. So if somebody were sick enough to be in the hospital and getting antiviral treatment, or on the rare off chance that somebody was getting antiviral treatment for monkeypox in the outpatient setting, you can stay on your HIV meds with that treatment. I think to the question about that many partners, there are all kinds of sexual behaviors and norms at this point in society. And there are also people who are sex workers, and there are people who are really at high risk for this. And so it's really hard to say who that is or why, but people do what they do.
I think it's important to note with that there is, I've heard that there is some then stigma about getting vaccinated, because there are people who may have had exposure but feel embarrassed sharing with the healthcare provider that they've had anonymous sexual partners or multiple sexual partners. And I think that's really important to, as Lily was saying, that you need to be a self-advocate in healthcare, that it's okay to be honest about those things, because it's going to, only with that honesty are you going to be able to get the care that you need and the vaccines that you're eligible for. I
couldn't agree more. And I really hope that it's nobody's experience that they feel stigmatized when they're in the room with a provider. But yeah, being open about your behaviors will only serve to help get you resources at this point. And we should not shame other people for what they do. So in terms of
Lily, real quick before you move on from that, in terms of, so I think the question that came in was specific. Actually, I may have been adding context to it, specifically around vaccination. So would someone who is living with HIV be eligible for vaccine, or would that only be if they've been diagnosed in the, I think 3 months was the period of time?
I would think somebody with HIV should be eligible for the vaccine.
Okay.
Yeah. Yeah. As long as they fall into that higher risk.
If they meet the
category. Yeah.
thanks.
What they mean by diagnosed with any STI in the past 3 months is if you've been diagnosed with like chlamydia or syphilis, those all qualify as being at higher risk for developing monkeypox and eligible for vaccination. And then a brief word on treatment. So similar to the vaccines that we have, there's no treatments directly targeted at monkeypox since this is so new and we're adapting what we have for smallpox. Most people, because we're in the West African strain here, will not need treatment and will have mild disease course, meaning they may have the symptoms that I discussed earlier, but it should not progress to complications. There obviously are always folks who are at risk of severe disease or those who actually get severe disease. And those are the people who would qualify for treatment and things that can put you at risk. So being immunocompromised, and there's actually a really full detailed list on, I believe it's on the CDC's website of who that includes, but it's folks who are like on active chemotherapy, on certain specific medications, those with solid organ transplant, children who are under 8 years old don't have the same immune function that healthy adults have. And then the question about eczema, we can talk about that more here. Those with eczema are at increased risk of severe disease or even infection in the first place because eczema is often sort of like an exposed skin condition. So if you think about your skin as a barrier of protection, people with eczema have even less protection from monkeypox than those with normal healthy skin. And then those who are pregnant also have a suppressed immune system. And like I said, the treatment is TPOXX, tecovirimat, and that's an antiviral used for smallpox. And my understanding is that that's not widely available yet and has been reserved for severe cases. Again, lots of questions. Let's see. Do these lesions leave you disfigured after the exposure like smallpox? That's a great question. I don't have like strong evidence-based data, but what I'm understanding is that once the scabs fall off and new skin forms, and from like few cases that I've seen, people are regrowing normal skin. I think if you're like any scab, if you're scratching, picking at anything, you can cause worsening scarring. But my understanding is that those with like not severe disease are recovering well and healing well from a skin standpoint. Is monkeypox a viral infection or bacterial? It is a viral infection. It's not a bacterial infection. So that means that antibiotics won't help monkeypox at all. It's a virus. It's a pox virus. That's why it has the pox ending to it. And it's treated with an antiviral medication in severe cases. But like most viruses, even like we see with COVID, but with a respiratory virus or anything like that, we typically don't treat those and they run their course on their own. And most people do really fine with kind of leaving them in supportive care. How long does this virus stay on your clothing? That's a very good question that I do not have an exact answer to, but I can look into that more. Does covering up protect you when out in public and riding transportation? Yes. So if you have lesions and need to be out, you should certainly cover up those lesions, and it can be with like bandages or cloth. And similarly for those who are trying to protect themselves from getting monkeypox, not having bare skin and practicing good hand hygiene are both things that will help prevent transmission. That is all I've prepared for today. Each section of this could be a lecture in and of itself. And I know a lot more data is going to come out the more we understand this. But if anybody else has questions or wants to chime in, I'm all ears. These are also the resources I used. There are some really great educational materials coming out of Mazzoni and Philadelphia Fight more locally. And like I said, the World Health Organization and CDC as well.
Awesome, thank you. So we'll give some time for folks to put more questions in the chat and the Q&A. One that I had that I'd heard, does the point of skin to skin contact, so for example, if I'm holding hands with someone who has monkeypox, am I going to get lesions on my hand, or are those going to show up anywhere on my body?
That's a great question. I would think that lesions could show up anywhere. Though I know that those who are getting monkeypox through sexual encounters are often getting them in the genital areas. Right. So I would imagine it's probably a little bit of both. I would think if you're holding someone's hand and they don't have a lesion on their hand and you're using good hand hygiene, that should be a lower risk than if you're touching someone's bare lesion. I think if a lesion touches an area of skin, it's possible that it would develop there. But again, I don't have that in hard data. And I think once your body is exposed and it's in your system, you can surely develop lesions.
Thanks.
But I can look into it more.
I'll take the next question. Yes, Wanda, we can share the link to the recording of today's session. Another question that just came in. So can someone get it just from briefly brushing past someone? So being on a trolley or a bus, like what does sustained skin to skin contact really mean?
Again, I think we saw this with COVID too, like we started drawing parameters around this. So 6 feet, 15 minutes, all these things. Brushing past someone, I can't say there's a 0% chance, but I think you have a very, very low chance of developing monkeypox and contracting it in that way. When they're saying prolonged, that is more than a brush past somebody.
And I did also want to share, I'm going to put this link in the chat just to the city health department's guidance on, I mean, if you're interested in like tracking all the data of cases and how much vaccine there is and how it's been administered, you can find that all up there. But also it just has as Dr. Flink shared in the presentation, kind of the guidelines for who can get tested, the numbers to call if you want to call the health department directly, if you believe that you've had exposure and you want to get that appointment as soon as possible in that 4-day window. So that there is in the chat.
I would say that especially now, and vaccines are going to continue to roll out. If you don't have an established healthcare site, it's really important to get established. I know that clinics who are offering vaccines are prioritizing their own patients. And I don't think I mentioned this, but it was in my notes. I know that Health Center 1 and William Way have been the main sites for vaccination. But I know that, folks who are going to Mazzoni also, and then I think Penn was also listed as a site in Drexel. Those are places that should be offering vaccines. I know that another shipment should be coming in around August 15th. That was my understanding, and that we should see a large increase in October of vaccine supply, but just being established so that you can get expedient testing, treatment if needed, guidance, and be plugged into vaccination is really important at this point.
And I'll just clarify for folks, the William Way has done some vaccine clinics. It's the city health department that's coming in. So William Way does not have a stock of vaccine. I think actually Mazzoni did one of their clinics at William Way as well. But yes, definitely do reach out to your healthcare providers.
I don't know exactly where the vaccine is being developed. I would have to do some digging. I know that what we have stockpiled is what vaccines are coming from that are being distributed in the US right now, but I don't know where additional supply is coming from.
These have been great questions. Want to give a little time for anyone to get any remaining questions in. And thank you, Dr. Flink, for answering all of these so well.
Thanks for participating, everyone. And I will look more into the question about that you asked about lesions, where the site of lesions will appear, because that's a great question. And I think just anecdotally seeing how people are contracting it and where their lesions are appearing is suggestive of that, but I want to give you a clear scientific answer on that.
Wonderful. Thank you. Oh, just got another one in. Oh yeah, so if you're, I know this is another thing that there's maybe still some discovery happening, but can the virus be transferred by touching, seats or poles on a trolley, or does it really have to be that skin to skin?
I have seen some suggestions of like shared surfaces, but I think it is not the predominant way that we are seeing spread. And I think using good hand hygiene, washing hands after you're on public transportation, especially before you're eating, using the bathroom, anything that's like going to come in contact with bodily fluids is extra important.
Yeah, and hopefully after 2.5 years of COVID, we've all gotten used to carrying our sanitizer with us, being more vigilant about hand washing. That all of that's gonna serve well for really most viruses.
Yeah, there's this nice graphic from the World Health Organization on advice on monkeypox for like gay, bi, and MSM population. So I'll just throw that link in the chat too, because I found it helpful and easy to read.
Awesome.
And then for people who have more questions, one of the resources that I found particularly helpful in preparing for this was the Mazzoni published their Q&A from a town hall that they did. And I thought it was very well done.
Oh, great. Thank you. Well, Dr. Flink, thank you so much for being part of the Doctor is In program series now. And hopefully we'll see you again this year. And congrats on the geriatric fellowship.
Thank you. Thanks for having me.
And yes, thanks so much for sharing all this information, answering these questions. Thanks to everyone who joined us either on Zoom or on Facebook or is watching this recording later for coming to receive this information and staying on top of this information. As we've said, there's a lot in the news right now, things constantly arising, but it's good to know the resources, good to know the risks and how to protect yourselves. Dr. Flink, I will leave you with the last word to close out on.
I just want to encourage everyone to be an advocate for yourself, speak up. And I know that, the healthcare system has not always been historically always like the kindest or most hospitable to marginalized populations, and everybody deserves equitable healthcare and treatment here and vaccines. And I just really encourage people to advocate for themselves.